All right, so good afternoon, everyone, and thanks for having me. I was just introduced. It never gets more awkward than hearing all of that about yourself, but my name is Lora Appel, and I've been spending the last few years looking at the application of digital technologies in health, and as was mentioned more specifically, improving care while in the pursuit of a cure. So this means I'm really focused on end user perspectives and preferences in the design and implementation of clinical interventions. And I think this nicely relates to the expertise of most, if not some of you here, because from what I understand, you're also focused on distilling complex information to non-specialized consumers. So, I mean, this is still a relatively different audience from the one I normally present to, who are researchers and clinicians. But I was actually very excited to prepare this presentation because it forced me to think about some very important actionable outcomes of my research that are never really the focus or at all even conveyed in academic publications or talks. So I'm really excited to share some of these things. I'm not entirely sure how interactive we can make this talk. It's something I very much welcome. I've had the painful experience of teaching virtually for the last 2 semesters, and I can tell you, I really empathize with students not being able to pay attention for more than 3 minutes to a talking head on Zoom. But I can already see more little faces on the Zoom screen now, so it's a refreshing change to my class and my normal lecture. I know that there's a dedicated question period at the end, but really I welcome comments throughout, while we're on a topic. It tends to be better to, when we're on the topic in the heart of something, for me to be able to recall important points and for us to generate conversation and actually make this talk much more relevant and interesting. So facilitators, please just chime in if somebody has a pressing question in the middle. Thumbs up, great. So I've titled this talk, Designing Virtual Reality for a Growing Aging World. I'm going to spend a little bit of time at a high level describing some of the research that we've undertaken, tease out some interesting design challenges that we've already faced, and suggest ways in which we can overcome, hopefully, these similar pitfalls in the future. But like all good researchers, I'm going to start off by defining some terms. Okay. So what is virtual reality, or VR? Basically, it's really actually hard to convey through words, but it's an experience that is created through a collection of specialized software and hardware that simultaneously stimulate multiple senses. So you actually feel like you are somewhere else. Unlike other technologies, it's quite unique from its immersiveness and the feeling of presence, or the feeling of being in another environment. And importantly, the ability to manipulate that environment. So you as the user can choose where you're looking, and this will change the scene. Or you can even touch and change objects or aspects in the scene. And this gives us as viewers autonomy and control over the experience and makes sure that our experience is unique, not only from anyone else experiencing it, but every time we experience it ourselves. And I have here actually, hopefully you can see, a common headset that I've used in previous studies. So this is, it's mobile, it's standalone, self-contained, relatively cheap. It's the Oculus Go. It's now no longer in production, sadly. And I also have here a much older VR headset, which actually I was looking at the bottom, and I can see that it has a patent from 1895, okay? And this is where I usually joke that, the cell phone goes in here. No, it doesn't. It actually comes with a bunch of, these split images that you lay in here. So you can see that the idea of virtual reality and experiencing 3D images and environments has been around for a very long time. So let's see, for example, while its rebirth, probably in the 70s or 80s, was a lot around military use and aviation training. It has more recently been used in healthcare for things like skills training. So, surgeons can practice surgery in a very safe and repetitive way. Clinic placements that are difficult often for example, nursing students to have, they can somewhat mimic in virtual reality. There's been a lot of use in virtual reality for cognitive behavioral therapy, having to manage, get over phobias or manage PTSD. And actually, just a few days ago, the first FDA approved device for pain, for VR and pain, was approved. So that's quite showing where the field is going. And it's also been used for screening and diagnostics. I'm going to talk a little bit about some of those examples. But what does this have to do really with our growing and aging demographic? And what do I even mean by the growing aging world? I believe many of you or all of you have already heard about this impending climate crisis called the silver tsunami. I actually really dislike that term. I think there's a far more concerning real climate crisis coming, but the silver tsunami refers to the world's aging population, that there are more and more people over the age of 60 than there were 20 years ago or before that. And this trend is really continuing as the baby boomers age, but also as birth rates decline globally. The Canadian Institute for Health Information actually predicts that in around 15 years, the age group of 75 or older in Canada will double. Already in the US, 25% of the population is over 60. And so, why you're thinking like, okay, why should we care? Well, for one, we really are already struggling to have the physical and financial resources to manage chronic conditions that come with people as they age. And increasingly so, they're not cared for in acute care settings, but they're cared for in the home by a circle of individuals, some of which who are professional healthcare and others who are just personal care providers. And this is really compounded by the fact that family and societal structures have changed. People live at a distance. You have global pandemics that prevent you from being able to physically go and meet someone. And really, on a fundamental selfish level, we should be caring about this growing aging world because we are going to be the caregivers, which is quite a lot of work. And maybe even more importantly, every one of us is aging. It's actually my birthday tomorrow, no joke. But we need to consider how technology will help us age and support us to age in place. The condition of aging is actually the most common one around the world, and it doesn't discriminate. Everyone ages, everyone's going to be facing these problems. So this is really something we need to tackle. All right, so let's talk a little bit now about bringing these two ideas together, the technology of virtual reality and what this can do for aging. It's very convenient because it follows along with my research, but there's lots of uses, as I've said, for VR possibly in healthcare, but we know that it's good at replicating environments and making people feel present somewhere else. And so we were thinking, how can this help certain groups of individuals? And in the case of my research, it's frail older adults with cognitive, sensory, and mobility impairments. These are generally people living with dementia, but who often lack the social and financial supports to go outside in natural settings that we know is beneficial for everyone's health. I mean, you aren't convinced by now, 20 odd months into the pandemic, that being isolated was going to cause you sadness and difficulties in life, then we have other issues. But these are individuals who, this hasn't just been 20 months, it's been, years, and much of their foreseeable future is isolated and alone. And while they might derive benefit from being in social and natural environments, things that can help manage different symptoms, they're unable to do so. And so we decided, to think about how can we maybe use VR to replicate certain environments and try and derive some of the benefit that we know in a safe, with all the benefits that virtual reality brings. The fact that we can repeat it, bring it cheaply, do it safely so people can visit other countries and not get, robbed. So there's even the physical safety, but the psychological security. And so when you start these kinds of studies with a new population and technology, the first step is really doing a feasibility trial and seeing, like, are there adverse clinical effects? Like, is this safe for these individuals? Are they interested? Are there anecdotal benefits? Like, is this possible? And so we ran a feasibility trial back in, I think, 2018 was when we started this project. And initially we had planned to run this just at one long-term care setting, but there was so much interest that, I ended up adding additional, we had a 4-site, multi-site study. And I had to cap it there, like there were more people interested. So clearly, there's a need for new solutions. And so we tried to see, like, our frail older adults with both cognitive impairments, but also mobility impairments, are they able to tolerate the weight of such a headset? What is their comfort level? What are side effects? How easy it is for them and the people within their care circle to use? Does it, impact So it wasn't very, there weren't very strong clinical outcomes at our first trial. It was just, were there trends indicating that this increases awareness when these individuals tend to have apathy, or changes in their posture, facial expression, movement. We did ask questions about positive and negative emotions. So this was a very successful feasibility study. There was a huge amount of interest and we had positive results. And so this led to another study. It was, so we followed up with a couple of clinical studies. This was a larger randomized control trial, which is like a gold standard in medical research to prove that when you're testing an intervention, the outcomes are due to that intervention. So we ran what I still think is the largest clinical trial of virtual reality in people with dementia at Michael Garron Hospital, formerly Toronto East General. So really here I was approached by a physician who's now my research partner, an internist, who was, desperate for a solution because current means of managing behavioral and psychological symptoms in people with dementia, I mean, really the only solutions they have are either detrimental, like, pharmacological interventions, which actually increase decline, speed up decline, or sometimes the interventions are unethical, like needing restraints. And so he was really desperate to find a new solution to manage some of these symptoms so that, these patients who often are admitted for reasons other than dementia can get the care that they need and then leave. And so this was an interesting study because it was in an acute care setting. So not only do we have all kinds of hygiene requirements or infection control requirements we have to meet, but there's a lot of change management involved because, this is one physician who searched for a solution. It's not like the hospital came to me and it's like, Laura, introduce your VR therapy. So it does involve a lot of change management, which is the most difficult part when introducing any technology, really. Patients were randomized here into different treatment arms. We looked at very relevant hospital metrics like falls, length of stay, again, use of medication, really because when you can move the needle on these kinds of outcomes, that's when the formal medical system will listen to you. Otherwise, you could be improving care as much as you like, but unless you can save some money, it's questionable whether you can scale your intervention. So the results, unfortunately, we actually had to stop this randomized control trial in March 2020. So we were still in the process of recruiting participants, but we got a significant sample size, and we're now writing up these results, which also were very positive on the side of managing aggressive behavior, which is, a number one issue, not only for patients, but also, again, for providers that care for them. Another similar in concept clinical trial that we ran was at Pearly Health. This is a veterans hospital in Ottawa. So here we were looking at, again, responsive behaviors, so verbally and physically aggressive behaviors that lead to staff burnout, but also, worse care for patients and are generally just a problem that has no current solution with this population. And so we wanted to see specifically around triggered events, which happen at predictable times, like if a resident is going to get their wound dressing changed. This is generally painful, and so it causes responsive behavior. And we thought, like, okay, if we, before such an event occurs, put VR on, relax the individual, distract the individual, can we mitigate some of the concerns that come out of this event? And again, we had very positive results, although some interesting aspects of change management, and on my part, conducting research at a distance, because I'm located in Toronto, and I'm not sure that is the best idea. So while that is not a suggestion for design, or rather the suggestion for design of research, keeping that in mind. But again, a very successful study that showed that there is benefit to providing this even in dire situations. So the last study I'm going to touch on just a little bit was community-based. We ran this with the Toronto Public Library. Initially, it was intended to have a person with dementia and their primary caregiver, like a spouse, co-create a personalized VR experience. This is because throughout our research, we found that customizing experiences does produce additional benefit. We also wanted to start looking at the relationship between these partners, because when you treat dementia, you're not actually just treating the individual, but it's very impactful for the entire circle of care. So we wanted to find a way to help capture a moment in time for the activity itself to be cathartic, So this was the idea. Of course, the pandemic hit, so we had to do a little bit of a shift, and we still worked with the Toronto Public Library. And I guess it was actually a year ago, last November, we ran an online workshop with intergenerational pairs. So we had grandparents and grandchildren. They got a VR camera and headset shipped to their local libraries where they picked it up. And once a week throughout the month of November, they joined me online like this with some other colleagues from Open Lab. And we ran a workshop teaching them to capture their experiences during the COVID pandemic. And then we also tracked like how did this make the team feel and how did they feel within each other, like as the relationship between the grandchild and the grandparent. Is it possible to teach individuals to do this on their own so that they can capture their own environments? Again, looking to in the future to push studies where we want to personalize medicine. I'm not sure if you guys have heard of this trend, but you know, the idea of personalizing medicine to people's particular genetic makeup, and also you know, to their goals and needs. And so this is, you know, we wanted to test to see if this was possible. And so really everything we've learned to date from the studies I covered right now, but also some other ones, we incorporated back into many more studies, one of which is about to launch in January called VRX at Home. And this is looking to provide therapy in people's homes. The truth is, doing research now at the lab is not really a possibility. So we all kind of have to deliver interventions in people's homes, but the reality is that that's where interventions are going to be delivered. So I don't find this really a barrier. I find this a positive aspect of COVID that research groups and hospitals are allowing for this kind of research more and more. So we want to provide VR therapy in the home. We want to customize it a little bit to preferences. We want to use the primary caregiver as very much a partner in administering the therapy. We're still going to look at clinical outcomes, but interestingly, we're going to really focus on communication and how this might improve communication, because oftentimes the breakdown in communication is one of the elements that leads to early institutionalization. We are still going to formally evaluate feasibility, especially because it's in people's homes. So it's still important. I always say we want to try and create something simple, safe, and seamless. And we want to try and foresee and overcome some of the challenges that we've already faced. So, and new ones that we haven't faced. You know, we're going to try and think through this ahead of time. So I'll talk now a little bit about some of the challenges we have faced. I won't mention low-hanging fruits, things like, can you wear glasses and then wear your VR headset? Or can you have hearing aids that are contraindicated with your VR headset? Because honestly, I don't know any senior that wears glasses or hearing aids. So I don't really think that that's going to be an issue. And I also won't talk about things like hygiene. Although, again, if you have questions about any of these, you know, we can talk about it at the end of the presentation. So let's take a moment and play a quick game of which one of these things is not like the others. I think Modern Sesame Street probably still has this little segment, but really, which one of these things on my slideshow right now is not like the others? I'm going to pause here. Someone chime in. They all look the same?
I'd like to call it out.
All right.
Felix says the Zenith remote because it's a classic.
Are you trying to make my presentation difficult? Okay, well, how about this? Imagine your grandparent, or for some of you, maybe your parent, picking up the white controls at the top right and intuitively manipulating them. I mean, like something like this, yeah? This is another version, but does this look like something that they use on a normal basis? You know, I want to think about what calculators look like, think about what car keys look like. These controllers for VR right now, the modern VR headsets, and increasingly so, are just so different. And intuition also comes from experience. And these kinds of controllers that are used to manipulate VR environments really don't fit the bill. Also, it's hard enough to tell the difference between the left and the right device. Like, I understand the need for sleekness and aesthetics, but also the font is usually like gray on white, which I'm pretty sure is not a good standard for anyone, let alone older adults who have vision problems. So yeah, this is like one example of, and one, you know, disappointment, for example, to shifting from the headset that I was currently using, which has less features, to more modern, headsets, which yes, have more bells and whistles, but are really not designed to be effective for an older population. So on the note of dexterity, I'm going to talk about another interesting anecdote I recently faced. So this image here is how you see your hands holding the controllers when you're in the VR headset. And I was recently visiting a colleague's lab at Toronto Western Hospital. So this individual, Dr. Reber, he uses VR as a tool to assess and improve vision in all kinds of populations, but also specifically in seniors who have age-related macular degeneration. And basically, they created virtual environments where these participants or the patients, they follow objects like tennis balls in a 3D environment. And this is supposed to help train their brain, both with vision and with hearing. But when I went there, what I noticed when I actually demoed their intervention was that at the end of the one trial of the game, I could only select objects with my right hand. And if you think about that, this is actually a very grave impact on the reaction time for people who are left-handed. Like the whole intervention might not accurately reflect their baseline speed at selecting something, but also any kind of improvement. Like they might have actually been able to follow the tennis ball, but they just weren't able to click on it at the right time. And it's even more interesting is that Dr. Reber himself is left-handed, and he still overlooked this important aspect. I mean, they're implementing the change now, so that, this is what happens when people interact and you find solutions together, but it's really not unique to their intervention. It is so common that most VR experiences are still designed for right-handed individuals. And this is just an example, but dexterity is a big issue for lots of seniors. And so using trackpads and multiple buttons and things that are not intuitive is not inviting for them as an intervention or as entertainment, honestly. But okay, last one here. What is jarring about this particular scene? This is not a trick question. Anyone?
Alex says the perspective.
The perspective. You guys are really making my job hard here. Okay, it's the red
big
dot.
Red dot.
It's the big red dot in the middle. So this red dot, this appears, and it's a feature. It's not even a bug. This appears every time someone in VR is casting their view to a secondary device. So, people can share in the experience. And sharing or mirroring a visual experience is especially important when guiding and comforting and for the safety of people in dementia when they're in VR, but probably also first-time users when they don't know how to use the device. So this red dot just breaks the immersiveness. It distracts from the actual experience. And sometimes it scares individuals. And as opposed to the other two examples, like we're still working on trying to fix this problem. Now that, we're going to really have this being mirrored in people's homes. So the person with dementia is going to look in an environment and then their loved one's going to watch it on a tablet. Like we still have to fix this. And in my mind, this shouldn't be so complex. I mean, I don't have a line straight to Facebook to be like, hey, Zuckerberg, can you fix this problem for me? But why are they not thinking about alternative uses of their devices? And so while there is this devastating need and lots of research, including mine, but others, that shows promising results for VR and older adults, we really have to think a little bit and talk about who VR really works for. I know I'm dating myself with this reference, but it's just, why is technology consistently designed like we're repeating the same mistakes and we're consistently designing it for only one demographic? A quick way to identify who VR is made for is just Google search VR, and the only images you'll see are pretty much young adults, mostly male. Okay, they started with a diversifying, backgrounds, but generally it's just younger adults. And so we need to consider our growing aging world and how we might implement inclusive design to meet older individuals' needs. Again, creating things that are simple, safe, and seamless. I think it was Winston Churchill who said that never let a good crisis go to waste. And while I think there's like a very thick silver lining to the COVID pandemic here in Canada, like there's increased acceptance of remote care in our formal healthcare system, all of a sudden, the government's like, yeah, we can make billing codes for virtual care. But there's also a much greater appreciation for the difficulties faced by seniors, those in long-term care, those who are isolated at home. Like there's just a greater understanding of how difficult their lives were before and how much even worse it got now. And perhaps this is not a coincidence, this situation in Silver Lining, that Facebook also decided to reveal their rebranding as Meta, or the metaverse. And this is really transitioning into virtual and mixed reality environments. I'm not sure if anyone here among the group has read Ready Player One, but to me, when I saw this keynote speech, really shocked me how sci-fi is just so close in the near future. So anyway, I wanted to focus on, in Zuckerberg's keynote, he starts off promising. He says, "This isn't about spending more time on screens. It's about making the time that we already spend better. Screens just can't convey the full range of human expression and connection. They can't deliver that deep feeling of presence, but the next version of the internet can. That's what we should be working towards. Technology that's built around people and how we actually experience the world and interact with each other." And that's what the metaverse is all about. Yeah, okay, great. But then he says, there are going to be new ways of interacting with devices that are much more natural. Instead of typing or tapping, you're going to be able to gesture with your hands, say a few words, or even make things happen by thinking about them. And I don't think he's thought about the fact that all these things are quite difficult for people as they age. It's not very easy to make repetitive gestures with your hands. Words become jumbled. Making things happen by thinking about them, this is very difficult for people with dementia. Another example I want to mention. So just, I said 3 or 4 days ago, the first FDA approved VR therapy for lower back pain device got approved. And you can see here, so I took some, images of, so their demographic maybe is a little different how they're selling it. It's for back pain, but you can see from the images that they've posted that, there's some older adults there. There's some silver gray hairs. But what I want to point out here is that all of these are just stock imagery of something that is so different from reality. I want to show you, a clip of older adults that I visit that actually need this kind of therapy. And that's what it looks like. It's not like a pretty clean home with a nice leather couch that reaches halfway down your back because we're on Swedish aesthetic, and everyone's able to move and your loved one is there. No, it's like a very small, tiny home where the individual can no longer sit upright. They're being cared for by basically their adult child who is another senior themselves. And so I really think we need to get down and dirty and actually talk about how we can use technology for good. And when we do so, not do it in such a sugar-coated way. Why aren't we just honest about what we need to do to change this technology so that it's useful? And I have another interesting anecdote for this research. It's yes, they show this older individual, the gentleman, and he's holding the VR headset with his hand. Oh, I can see time. But the truth is, I've heard a lot of comments that the VR headset is quite heavy for frail individuals, and so they actually need to lean back in their chairs to balance part of the weight by balancing their head. And so for this, you need a high-backed sofa. You need instructions on where to look. And so there's lots of things we can implement ahead of time to try, even if it's not to the hardware itself, but to instructions on how to use things to make this more helpful in the future. And so what can we do to raise awareness, to bring these other perspectives to the table, both within research, I've mentioned a couple, but also in the development of the products. So in healthcare, there are often what we call best practice guidelines. These are indicators that have been agreed upon by consensus in a body of experts in the field about, what's the best protocol to follow. And at our lab at Toronto General, our clinical director often says, well, this isn't rocket surgery. And he's completely right. It's not complicated, but it is hard. There's no need for, incredibly skilled work here. Although, I don't want to say that because I'd be losing my job, but it requires, I think it requires skills that I think everyone can hone. Things about being more humane, understanding, having patience, being observant. Some tips to get you started on this is always involving the end user, having them identify the issues they want addressed, and having them, create the interventions and talk about how they want to evaluate them. So actually the image here is not stock imagery. That's my friend Barry from Alberta. He is not your typical 83-year-old retired architect. He's got this like passion for flying, and he trains in VR every week. And actually he goes and visits other seniors who are caregivers for their loved ones with dementia and teaches them how to customize to use VR for their loved one. And so, I can't tell you what a great resource this individual has been. He's now an advisor on our committee. But every time I speak with him, there's like a wealth of knowledge about people's real experiences and difficulties in using that. So, definitely connect with end users, visit the real environment. I think there was this show, I don't know if it was called Dirty Jobs or something like that, where like management would go and do entry-level work at their business. And I think that's what you have to do. I can't be a high mighty researcher with all these ideas and never actually go into people's homes and see the difficulty with my own eyes and see the reality. And so, yeah, visit their actual environment, listen to their needs. I said, personalized medicine, it's not just about providing pharmaceuticals, but it's about addressing people's needs. Always remembering that in pursuit of a cure, we can give proper care. We can address people's preferences and goals in life. They differ. And so there's no reason that we shouldn't be paying attention to that. And always collect qualitative data. Okay, I really struggle with this myself. I am a mixed methods researcher, but there is within research still a bias towards quantitative data being that which proves a better outcome. And every time I've done a research, I've forced myself to include qualitative elements, and they have undoubtedly been so much more meaningful and actionable, and made me have the ability to design my next study better. And so I'm convinced that this is also the case in designing products as well. So while it's complicated and resource heavy to both collect and analyze, like, I don't know if there's anything more useful than qualitative observations and data. And again, like, VR is not for everyone, but nothing is for everyone. Not all pharmaceuticals are for everyone. So we, keep in mind, I guess, that the technology is, we're not trying to like, find the solution for everyone in this one technology, but we can learn other things that are applicable for other interventions. And so, I'm going to end like there's a challenge, but it's something we can overcome. We can choose to think a little bit ahead, more so than we've done in the past. I don't know much about sports, but I do like this one quote by Wayne Gretzky where he says, "Skate to where the puck is going." And this not only means like, think about the world's population and where this is actually going to get used and implemented. But also, yes, I said like these controllers aren't intuitive, but in the future, seniors will have been people that would have grown up with a little more familiarity with these kinds of things. So there is a balance, but always, the idea of designing for the extreme obviously will include in it people who fall more within the bell curve. And so I guess we've reached now, I guess it's almost time, but we've reached my final Oscar thank you speech slide. Of course, none of the work that I do alone. I do this with a team of researchers and volunteers. And we're also very thankful to our funders who even years ago believed in this kind of research, pre-COVID and pre-virtual care. Like Oscar speeches, there's not an exhaustive list. So if you want to visit our website, prescribingvr.com, you can see everyone who's been involved. You can read about all of our projects. And yeah, I'd like to thank you guys all for inviting and listening to me, and I welcome questions.
Thanks, Laura. It's been great to see how these projects have evolved through COVID and the opportunities that technology has presented based on our last talk and yours. We have a question here in the chat from Contessa. Hi, Laura, thank you for the presentation. Is this device available on the market, and will cost be covered for patients with dementia or other illnesses, or do patients need to pay out of pocket? Okay, that first of all depends on which market you're in, if you're in the Canadian market or in the US market. The hardware is off the shelf. Most of the hardware that I've used for my research is like Oculus Go, Samsung Gear VR, most of the cheaper mobile headsets, which are available now at Best Buy. The software itself, we are still working on, probably with the intent to, yes, create a clinically valuable product. And, the business plan is still under question. I think, we would, if we could
if we have strong evidence, as is the direction and trend now, that this is beneficial for managing some of these symptoms in a much safer way, I am hopeful that the government will be able to cover or subsidize some of these costs. Whether it's provided in the hospitals, then probably the hospitals themselves would cover the cost, but for in-home care. But it's not as a complete product available yet. We're still in the research phase.
Nice. We have another question. How do you reconcile clinical applications with Oculus and Meta's privacy policies?
Yeah, I really don't like them. And I think we're at the point now where we're just running studies with this hardware because I don't have infinite funds to build my own headset and my own hardware. But I think that if we find that it is effective and we can package things together, that we will start to partner with like Canadian VR headset producers and like, yeah, distance ourselves from Oculus and you know, potentially other hardware manufacturers and software that just, you know, infringe on privacy rights.
Jenny, you've got a question.
Hi, thank you so much. That was a really great presentation. I have one question. We know that among a lot of senior citizens, especially those with dementia, the line between reality and their perception of reality can already be quite blurry. How can we use virtual reality to support them without complicating this problem?
Yeah, so this was an element that we started off looking for, and we still do now when we take baseline measurements prior to any participants participating. We actually didn't find it to be as big of an issue as we thought. And so this leads me to believe, and I think this is what we would implement in a product, is just, again, we have to customize this. So based on people's physical abilities, you know, what has been reported by their family members or the institution where they live, and do and trial and error a little bit. So we'd have eventually something that, you know, should they experience one of these VR films and it have a negative reaction, we try and understand why and no longer show that or improve it. So it has to be an iterative process and it has to be a customized process. But that being said, it really hasn't come up as much as we thought. Less the confusion between reality and the virtual reality, perhaps also because, you know, they can't yet ignore the fact that they feel the physical headset on them. So in some ways, maybe it's okay that they feel like, you know, things I've heard is that, yes, I feel pressure, but it's worth it. So it's not that they don't feel that it's a bit uncomfortable, but they kind of tolerate it because it's interesting. And maybe, you know, unintended benefit of that is that they aren't completely immersed. Now, with time, as technology gets better, that might happen. And I think in those cases, you just have to be cautious with the experiences you show somebody.
Thank you.
We've got another question. I think time for one more before break. Is there any idea of brain scans while they use this technology?
Yes. Yeah. So not only brain scans, but there's also other kinds of biofeedback that we want to look into that's a little more, again, objective and quantitative metrics we can gather while individuals are in this to try and, you know, describe benefits or changes. Brain scans in particular are difficult because we can't put them in an fMRI because some of the device is metal. But I think there are interesting solutions being designed, and also as the technology gets a bit better. So the short of it is that there is an idea of it, but it hasn't quite happened yet. But there's like, you know, eye tracking, gaze tracking, you know, you can put other kinds of like wearable technology to try and get feedback. So that might happen before the actual brain scans.